Hi, everyone. Welcome to Hernia Talk Live. We're here on another Tuesday. We call them Hernia Talk Tuesdays. I'm your host, Dr. Shirin Tofi. I'm your hernia and laparoscopic surgery specialist. You can follow me on Twitter at HerniaDoc. Same on Instagram at HerniaDoc. Many of you are joining me today as a Facebook Live at Dr. Tofi. And thanks for those of you that are logged in. I see many of you already on Zoom. And as you know, this episode and all prior episodes, I think we're up to 160 by now, will be available to you to watch, review, share on my YouTube channel, also at HerniaDoc. And if you're like me and you actually enjoy podcasts, then you can just listen while you're driving, because we also have it as a podcast at Hernia Talk Live. So all those are available, and I'm really excited because we have a guest. I think you're our first guest of the year, Jake, Dr. Jacob Greenberg. He's awesome, one of my favorite people in the world, and you'll learn why once you kind of go through the next hour. He is currently a big deal surgeon, hernia surgeon specialist, but he does so much more at Duke Hospital in North Carolina. You can follow him on Twitter at Duke Hernia, which is an appropriate moniker. So welcome, Jake. Thanks so much for accepting to be a guest.
No, thank you so much for the invitation. Anytime I get a chance to hang out with you for an hour, it's always fun. So this
You're
was
so
no
sweet.
brainer, yes.
So Jake's been great. He's held many different positions. You do minimally invasive surgery, bariatric surgery, weight loss surgery. Your current role in Duke, I believe, is also in charge of their educational program. Is that right?
So Division Chief of Minimally Invasive Surgery.
Okay, great.
Yep.
And you have fellows that you have to teach
We have
and residents.
three MIS bariatric fellows who
Oh,
are
three. That's a big
yeah, they're
program.
a fantastic group, and that's led by our wonderful program director, Dr. Kenora Jane Spangler, who's a bariatric surgeon who
Wow.
is great. So
And how much of what you teach clinically is hernia related?
So my practice has now really kind of moved almost entirely to hernia.
I mean, why shouldn't it be? It's the most
And
fun.
it's so much more fun.
So
It's so
much
much
better
fun.
than other specialties. Okay.
I like everything MIS. Like I like bariatric. I love benign foregut and flex endo and hernia, but the hernia stuff is just it to me is like it's the passion. It's the thing that's the most fun to do. And so we have a lot of great surgeons at Duke who all like to do a lot of great things.
Yeah.
But there's a big, really fantastic group in bariatrics, and my contributions can be much more on the hernia side, which works out perfectly for me. So
Oh,
it's been
that's nice. So you have a close relationship between weight loss
yeah,
surgeons and hernias. You kind of need that.
we do. And so our hernia center and our weight loss program are all housed within the same clinic, and there's a lot of free flow of
Okay.
patients between the two, which makes a ton of
That's
sense.
great.
Yeah.
Yeah, we had JB Bittner on I think a year ago or a year and a half ago. So yeah, he was able to also bring us that vision of like a hernia surgeon that does bariatric surgery, understanding how the two are somewhat interlinked.
Yeah, I mean, I think so much of what we do is predicated and dependent on how well patients are prepared for that surgery, right? And patients who are smokers, who have who are obese or suffer
Yeah.
from obesity and or diabetics, the more that we can get those things under control before surgery, the better the patients do. And so seeing a lot of patients with a lot of those comorbidities, you can help guide them through their care in a much more meaningful way and be involved in them from sort of the start to finish. So it's a great combination.
So our group is also MIS bariatric. So the Cedars-Sinai MIS bariatric. We used to have two fellows. We went down to one, but we've maintained the good balance of both MIS and bariatric
Yeah.
education. But yeah, so when we do journal clubs, every so often they throw in a hernia, article. And because they do so much bariatric, it's like a hernia in the obese population or hernia in the bariatric population. And it's so interesting how the minute you bring those two topics together, everyone goes nuts. Like it's as if there's no standard. They're just have their own ideas, and to me it's very clear. I mean, it's not very clear, but I kind of have like an algorithm in my mind. But if you don't do a lot of hernias, then and just bariatrics, when you throw in the hernia part, some people don't understand how to like balance the hernia repair with the bariatric surgery and vice versa.
It's really, really interesting too when you read the literature, and it all depends on like whose perspective it's written by, right?
Yeah, exactly.
The surgeons writing it, like it's pretty clear that the outcomes of hernia surgery are actually they're okay in obese and morbidly obese patients, right? Like
Yeah,
they can do okay. They clearly do better if they are on the lower end of the weight scale.
yeah,
Uh, but when you look at the outcomes in bariatric surgery for patients who have hernias and concomitant bariatric surgery, like their bariatric outcomes, the outcomes of the procedure are a little bit worse because the comorbidities are usually higher. And then the morbidity and the potential mortality is a little bit higher. So from a bariatric standpoint, it really like doesn't make a lot of sense to do hernia repairs at the time of bariatric surgery. Like do as little as you can, get
yeah,
out.
yeah. It's totally okay. People
Yeah.
call me all the time, either during their surgery or before they're as they're planning, and they're like, I have this big operation. Let's say they're taking out a big tumor or cancer or like infection or whatever. Like, but the patient has a hernia. What do I do with it? I'm like, don't do anything with it.
Yeah.
And they're like, what do you mean? They feel like just because there's a hernia in their face, they have to fix it. I'm like, no, don't screw it up. Do the life-saving procedure and then come back when there's time to do a
Totally
good
agree.
job, do a good hernia repair, right?
There are definitely times where I think it makes sense to do them both together, right? Like certainly like ostomy takedown, like things like
Mm,
where like you
yeah,
can actually intervene and fix the problem. But like when you're there for some other reason and there happens
yeah,
to be
don't
a
mix it.
or close them primarily, right? Like don't make anything more complicated than it needs.
No,
Just come back and fight another day. It's always
yeah, I agree. So that's where the education comes in. Often the residents call me, and I think it's great that your group is also kind of intermingled that way because the ultimately we're teaching the residents, right? And we're kind of teaching our own colleagues too, but we're teaching the residents because for them, they need to be able to kind of have like a system of it's not random, how we provide hernia care. There's a system and there's a algorithm that goes through each of our minds. So
I
do you
think
have like hernia journal clubs and you have
we
people doing
do.
research with you? Like what kind of educational programs are part of your residency and fellowship?
So we have our we call it First Friday. So every first Friday we have a lot of education for our fellows and the residents that are on the team.
Yeah.
1 hour of that in the morning is our complex hernia conference. So it's a system-wide conference. Usually our plastic surgeons, a lot of our sort of community surgeons, and a lot of the MIS bariatric and hernia folks there. We present cases. Everyone pulls the most sort of complex stuff that they've seen in clinic, and it's a great way to sort of vet the cases with everyone who's interested.
Mm-hmm.
If anyone has any good ideas or thoughts. A lot of times it's a lot of really super complex patients who maybe surgery actually isn't the best thing for, and at least then
Right.
you everyone together to sort of come to that consensus, which is good. And so then usually we have sort of like a full day of education that extends beyond that. So our fellows tend to lead it. Oftentimes it's focused on bariatric because we still are mostly primarily a bariatric fellowship, and
Mm-hmm.
but they'll also talk about all the other sort of aspects of an MIS bariatric fellowship, and it's just a great educational day that's usually fun. We're all kind of sitting around in this one communal space in our clinic, and it's just a nice time to get the whole team together and do a lot of education around it.
So
So yeah.
I think you're significantly younger than I am, but I think like training wise, we're probably the same generation where hernias were not cool when we were training.
No,
It was not what people wished to do, or even definitely there was no hernia specialty discussion
no.
back then. But now there is.
And it's great. And now, like the Fellowship Council is opening a designation for hernia and abdominal wall
Mm-hmm.
surgery fellowships,
Yeah.
and there are a lot of people that have seen surgeons like you, who
I
they
love it.
as role models, and that's what they
Yeah.
want. And I think that's great.
Yeah, they love it.
No,
And then
I
yeah.
totally like I made every like wrong decision in life, probably in life, but definitely in residency.
Yeah.
I was applying in colorectal. I really liked laparoscopic colon surgery, and thankfully, my wife, who you know, and who's also a
Yes,
surgeon,
she's
was like,
great.
"You're applying in the wrong fellowship. Like, you don't like that." She's like, "You just like MIS." She's like, "You won't
Mm,
come home happy after days where you've done lap choles, lap inguinal hernias, lap ventral hernias, lap colon." She's like, "You just like laparoscopy."
yeah, that was my life before.
So you should just do that. And I was like, aye, aye, Captain. That
Yeah.
sounds like a good plan. And in fellowship, my fellowship at UMass was largely bariatric, and I did a little bit of the complex hernia stuff because they were the ones doing the endoscopic external oblique releases at the time.
Yeah. All right.
Then when I got into practice, I just sort of said, "Oh, I love inguinal hernias. I like ventrals. I'll happily see everyone." And then the floodgates just open,
Yeah.
uh, and it just becomes your practice. And I fell in love with it.
Yeah. People always, the residents always like, how'd you get into this? And it's like, it wasn't a straight path, but I love what I do and they see that. So I think people that like come to you and they see you're like so happy with what you're doing that they start thinking, oh, maybe this is a good specialty to do.
And also,
We have some,
you make people better, right? Like they
yeah,
come in,
you
you
do.
make them better, and then they're happy and they go forward, and they don't have like a bad terminal diagnosis or something that's really
Yeah.
awful. They
Yeah.
have they have a problem that we can fix, and we can then help them.
So our audience is asking some questions that are a little bit
Perfect.
off our topic, which is totally fine. So maybe you answer some of them and I'll answer some of
Yeah.
them if you know what. Okay, so we'll do question number one. I'm being evaluated for groin pain and possibly an occult inguinal hernia. A CT scan and ultrasound showed nothing. We know what that means. I will likely have an MRI next. Question. Is your MRI protocol standard? If not, how do I advocate for that protocol? And would such an MRI capture possible other causes such as hip or low back pain? So they're referring to the MRI hernia protocol, which I sat down and made up with our radiologist, and it's been so helpful because it's not really a hip protocol, it's not really a pelvic protocol, it's not really a sports hernia protocol. It's really based on Valsalva and getting the right pictures for hernias. And I do get pushback from different radiologists outside of my region because they either don't have that protocol or they don't want to do it. It's extra work. It's not their own protocol. Have you had experience with the same MRIs for hernias?
So I think it's very institution dependent, as you're
Yeah.
saying. Like most institutions, it's been protocolized by the radiologists, who I think really are trying to do what they view as being the best thing for the spectrum of disease that
Yeah.
they see. Most of the places that I've been, any groin MRI that's looking for something is usually protocolized for like a sports hernia. That's been the most common thing that I've seen by far. And ours, I've never been at a place where the groin and hip are sort of in the same protocol. It's usually two separate ones, looking for
Yes.
labral hip tears, femoral acetabular impingement, or looking more at the groin for sports hernias, osteitis pubis, and that spectrum of problems. So I haven't been in a place where it's been protocoled to look at the two. To me, that makes a ton of sense because there's so
Hmm.
much overlap in that spectrum of disease, but I haven't been in a place where that's been the case.
Yeah. So the MRI protocol, it's free. It's on my website. You can download it. I always have the patients print it because it has like radiology language on it to take it to their radiology group and see if they can replicate it. But it's basically an MRI pelvis with no contrast. It will look at the hip and the lower back, though it's not intended for that use. So it's not like the best study for spine or hip, but you can still see it. Um, and yeah, you can, there, there's still ways of like encouraging a radiology group to use that protocol because some of the sports hernia protocols, which may be standardized for in an institution, they really focus on inflammation and tears. They don't include Valsalva, for example, which for a little hernia or occult hernia, especially if you're laying flat, it would be helpful. Um, but yeah, you can just print it out. You can even call my office. They can give you a copy. But it is, if you just Google MRI hernia protocol, it should show up. It's one of
That's
the
awesome.
documents. Yeah, yeah. We have it at the IHC too. Yeah, it's easy. Next, how do you manage, oh, this is a good one for you. How do you manage omentum severely enlarged by fat when doing a laparoscopic hernia? So a fatty, large omentum, maybe in a hernia or something?
So I think it all depends on kind of if it's in the defect or not, right?
Yeah,
One, I think obviously usually getting a little bit of preoperative weight loss to try and decrease both visceral and peripheral fat is always helpful.
yeah,
Historically, I think that was always a really challenging thing, right? Diet and exercise, they're tough. It's really hard to lose weight, period. Um, the medications nowadays are much more effective than they have been in the past. They're hard to get.
Yeah. Do the medications reduce visceral fat the same as like overall fat?
I haven't seen anything that has definitively said that. I think it reduces overall fat. It also clearly
Hmm.
reduces muscle, right? I think there's some muscle loss associated with that too. But it is, I mean, they're pretty good now. The GLP-1 inhibitors, the semaglutide, tirzepatide,
Yeah.
they're effective in a way that we really haven't had in the armamentarium in the past. They're just a challenging thing to find now and get covered for insurance for some
Yeah,
patients.
that's true.
So if you can do that, that's great. Obviously, I'm biased as someone who's always done bariatric surgery as part of their practice. I mean, I still think that's to me the gold standard. Like it just is incredibly effective in a really good way for patients to lose weight and improve their overall health.
Yeah.
Uh, so I think those strategies beforehand are great. If you're in the operating room and having to deal with that, I would try and, as much as possible, just not have to deal with it, right? Like try and, if we're doing especially a minimally invasive approach, reduce whatever momentum that we need to reduce, let it lay down on the floor of the abdomen and deal with whatever's
You
on
just
this.
leave it. And
Yeah.
I think the other part of that question is when you go in there, laparoscopically, you need space to work in, right?
Yeah.
But in someone who's morbidly obese, a lot of that space may be taken up by big chunky omental fat. So, um, you can't do much about that, right?
Usually you still have enough room to
Yeah.
work. A lot of it depends on our patient's body habitus, right? So there are there are patients where their fat is like distributed throughout their bodies, right? Like
Hmm.
when you lay down on a bed or lay down on a table, you can feel their rib cage and their abdomen's actually fairly easy to access, and they don't have as much intra-abdominal or visceral fat.
Okay.
And there are those that have skinny arms, skinny legs, and just a big belly where it's all central obesity. And that is definitely much more challenging. Um, and so for sure, I think for those latter patients, trying to get some preoperative weight loss is critically important. I've
Yeah.
never I've never been a big believer or fan of like sort of omentectomies during the time of repair to try and like get more space. Like I don't want to take anything out. I just want to fix the hole.
Yeah.
And so I think really more importantly, preparing patients adequately for surgery with preoperative weight loss is probably the right strategy.
Going back to the hernia protocol, the follow-up answer or question is, thanks so much for the answer regarding the hernia protocol. The surgeon I consulted with is skeptical of an MRI showing anything if a CAT scan or ultrasound shows nothing. Of course, our study shows the exact opposite. So CAT scan is shown to be the worst for looking at inguinal hernias in general, especially the smaller ones. Ultrasound is pretty good. Um, so if it's a positive ultrasound, it's almost always correct, but if it's a negative ultrasound, it's correct about half the time. And then MRI has the most sensitivity and specificity, specifically looking at like occult hernias and so on. Uh, so what are your thoughts about people who are like, oh, because I've seen people clearly have clinical symptoms of a hernia, inguinal hernia. Ultrasound shows a hernia. Surgeon's like, we gotta get a CAT scan. Okay. So the surgeon gets a CAT scan and it doesn't show a hernia. Well, it probably does show a hernia, but it was reported as as not being a hernia, probably incorrectly. And then they like, you don't have a hernia. So what are your thoughts on that? I'm sure you've heard similar stories.
Yeah, I mean, I tend to think that we try to like reinforce our own bias of what we've seen
Yeah.
with whatever information is going to make us feel more comfortable about it, right?
Yeah, I think
Um,
surgeons are so comfortable with CAT scan.
yeah. I personally like ultrasound for the occult hernia for a
Hmm.
couple. One, I think it's a cheaper study.
Yeah.
In general. Two, it's more dynamic, right? Patients can Valsalva, they can move, and if your ultrasonographers are really good, they can see stuff moving that you just don't necessarily pick up on CTs, which are more
Yep.
static. So
Yep.
I've generally tended much more towards the use of ultrasound, and for me, like if I can't feel the hernia in clinic, my first step is an ultrasound. If the ultrasound shows a hernia, I'll usually go forward with
Believe
not.
it, right? If the story makes sense and then you have some imaging to support it.
And I mean, I don't know how you were as a resident. Like I hated going to clinic as a resident, so I never went, and I like never knew how to do a good hernia exam until I was like a fellow or like a junior attending.
Yeah.
And still to this day, like I'm pretty good, but there are clearly patients where I have not felt one at all. And I've been like, it's going to be negative. And the ultrasound, you can clearly see it. So we're certainly not perfect on physical exam. And for those patients where the story fits, the ultrasound shows
Yeah.
it, like I just go.
I hate to admit my residency bent. I hated hernias. So you at the county clinic, do you remember there were these paper charts, right? And then they were kind of, as the patient came in, they put the paper charts in. So you pick the first one because that's the next patient. If it was a hernia, I'd put it in the back. I'd take the next patient, hoping the other resident would pick up the hernia, and I'll just do like the gallbladder
Yeah,
consult
it's
or
perfect.
something. I hated it. I don't know why. I think I was uncomfortable with the examination. I was a junior resident, so I didn't really appreciate. It was I understood gallbladder disease better than hernias at that
Yeah.
time. I still feel guilty because the hernia patients probably waited longer.
I think it's
Whenever I was in clinic.
I think it's probably fine. No, and so I don't know what it's like for you nowadays. I also see many more patients coming in with like unnecessary radiology studies. I don't know if you're seeing the same thing. Like we see a ton of patients who
Tons.
like, have a clearly palpable inguinal hernia, right? And to me,
Yes.
if you can feel it, like the ultrasound isn't going to change anything that I'm
Yes.
going to do for that patient, right? So you feel it, and they've come to you already from their primary care doctor who's trying to do their best job, and they've gotten either an ultrasound or a CT that probably they didn't need because they just could have
Yeah,
come
they
in.
had a typical hernia. You don't need
Yeah.
imaging for that.
And so I kind of feel like that's,
Yeah.
I don't know what's led to that change, but I feel like probably a surgeons maybe were partially responsible because for saying, well, you sent them without any imaging, like get the imaging for,
Yeah.
but like there are definitely patients paying for procedures and for interventions and studies that they probably don't need.
So do you
Unfortunately,
have a good ultrasonographer at Duke?
we do. Yeah,
Oh, that's really important.
great,
Yeah.
helpful.
Right around the corner, there's a private radiology group of 3 radiologists that do hernia ultrasounds. And one of them's like the eldest one. I wish he literally called me. He's like, I heard you like hernias. I'm like, I do. He's like, I like them too. Send me your hernia ultrasounds. I was like, really? You want that patient
Perfect.
population? He loves it. He like talks with the patient, moves them around. His reports are perfect. Like, I hope he never retires because it's so hard to find a good ultrasound. He's a
So,
radiologist himself, does it, not the tech. It's great.
that's so helpful.
Yeah.
So
Okay, here's a question. It really relates to the mesh plugs. Do you think there should be a do you think there should be a ban of mesh plugs, or what are your thoughts on mesh plugs, I guess?
so I I have a conflicted thought on mesh plug. So I remember as a resident, like training in the time where plug and patch was like kind of taking off in popularity.
Yeah,
And a
you
ton
are
of
younger than me because it came after my residency.
Yeah, it was I put in a lot of plug and patches. And I remember as a
Yeah,
resident, because you don't really follow up patients as a resident, right? Like you see them for that snippet in time and you're
yeah,
done. Like I thought it made sense and it was good. And then as an attending and faculty member, the overwhelming majority of my interactions with plugs is removing them for pain.
yeah,
So I don't. I think once I learned how to do a really good Liechtenstein, you recognize that the plug probably isn't really supplementing anything to that repair, right?
yeah,
Um, and so for an opening inguinal hernia repair, like your high ligation of the cord is going to take care of the indirect problem, and then your mesh reinforcement is going to take care of any direct problems. And so the plug probably isn't helping. For femorals, um, for the most part, as an MIS surgeon, like I am biased way more towards minimally invasive approaches. I just think that
and simple flat meshes. Yeah,
yeah, right. So a simple flat mesh that covers the whole 3 areas where hernias can form in the groin and the femoral and the inguinal spaces to me just makes much more sense than rolling up a piece of mesh and shoving it into a hole.
this
And
is
not
true.
knowing where it's going on the other side of that hole.
This is true.
So I really think that for every hernia that's amenable to it, the MIS approach tends to be a much better way to just fix things. It just I always kind of like go back to, if you blow a tire, you patch the tire from the inside, not the outside. Um, and I don't know.
We've had urologists that put in plugs robotically,
Yeah.
like even the opposite way. It's just the weirdest thing.
And
Not
you
a
know
good
what?
idea, obviously.
I'm sure that for patient, I'm sure there's probably a huge number of patients out there with plugs that are perfectly fine. Right.
Yes, there are. Yeah.
I really think there are. And so we see sort of we see a numerator of the denominator, right? We see part of that fraction and we don't see the whole thing, but the part that we
Yeah.
see hurt by it, I think kind of gives us our perspective on what we feel as surgeons is the right thing. And so to me, I think a flat piece of mesh that covers all those holes makes much more sense than something shoved into one.
Well, we looked at our data, we published our data on mesh removal, and I totally thought that mesh plug would be top on the list. Plug, probably hernia system, and then flat mesh. And it wasn't. I was taking out flat mesh more often. I think meschoma, specifically meschoma, is more common with the plug. So maybe like in that small category, but in terms of overall mesh removals, whether it's for infection or nerve entrapment or something, it's not necessarily, at least in my practice, I thought it would be the plug, but looking at the numbers, it wasn't.
But I
It was
think
a
it's
close second.
I think that's one of the reasons why like people like you and David Chen and people that see a lot of the chronic groin pain patients are so
Yeah.
important, because just the majority of surgeons, I think, don't have that experience to
Mhm.
really and to see what they see, right? And so for you guys to like see it, think about it, write about it, take care of it, like it's incredibly helpful to us that don't see as much.
Yeah. So tell me a little bit more about your hernia education program. Do you like take the juniors through opens or the seniors through opens? Like, uh, how much of it is lap or robotic? Do you feel like they're getting good enough range of education before they graduate?
So I think we have a good mix.
Okay.
So one, we have a phenomenal it's called our SEAL program. It's our essentially our inanimate training program, right? So
Yeah.
we do a lot of lab-based work. So and that does include some porcine models, so some pig surgery, where they get to do a bunch of different hernia repairs in pigs,
That's
which
so
is great.
good.
It's an opportunity for them to practice when it's outside of patients. So they get really good exposure to stuff in an inanimate setting, in an animate setting, in an animal lab, and then obviously a ton of the different procedures that we get to do with them in patients. So we have on our service, we have the 3 fellows, we have essentially a PGY3 resident, and then we have interns on the service as well. The interns are frequently involved in a lot of the open inguinal hernia repairs, in the uh, umbilical hernia repairs. In the smaller cases, the mid-level residents are doing a lot of the sort of lap umbilicals, lap ventrals, as are our fellows. And then the fellows and the residents also get to do a mix of the bigger, more complex stuff, including ETEPs, robotars, open transversus abdominis releases, bigger ab wall recon. So they get a good exposure to kind of everything, which is nice.
That's really cool. Um, I always, I do the education too for hernias. And one thing I tell them is a tidbit, which is, first of all, no matter how simple a hernia is, it's very important that they understand it. It's kind of cute to do these like big reconstructions and so on, but a good simple inguinal hernia or a little umbilical hernia, understanding the intricacies of that is also super important. But did you know this? The number one most failed question on the oral boards is the hernia question.
Which one? Is it inguinal or is it ventral?
Inguinal one.
Is it really?
Yeah.
Have you had to do your 2-year recertification thing yet?
Yeah. Yeah.
So I did my first one, I can't remember, like 3 or 4 years ago.
Uh-huh.
And I like sat down and I was going through questions. I got like the first 4 right, and the fifth question was like a patient with an inguinal hernia,
Yeah,
and
I got that one wrong.
I got it wrong. And I was like, man, how did I possibly get this wrong? And I was so
Yeah.
angry that like I went through the whole rest of the test and I had to go back and
Yeah,
retake.
yeah, I mean I passed it. I'm recertified.
Yeah.
But You're right. The hernia questions, I was like, oh, I know this answer. And then
Yeah,
I got
totally
it
got it wrong.
wrong.
Totally got it wrong. My first
I don't
wrong
know if
answer.
I was reading the question wrong or I,
Elderly female patient with an inguinal hernia, and I did the wrong thing. So
I think I know too much.
yeah.
Maybe that's what it is. Okay, here's another question. What type of scan or ultrasound would you need to show nerve entrapment in an incisional hernia? I have two lots of mesh, one on top of the other, Priatex and Proline mesh. Why are you looking for nerve entrapment is what I want to know.
Yeah.
That's
I
not
don't
usually
know that
a
there's really any
ventral hernia
scan
issue.
that's good enough to determine that in and of itself.
I mean,
Usually if
CAT scan for abdominal wall, CAT scan's perfectly good.
they're good, but I don't know that they can necessarily see if it's entrapped, right? I mean, I think to
Why
me
would
that
you have a nerve entrapped in a ventral hernia?
uh,
Like laterally if they put stitches?
where they put it or how they fixated it.
I guess
Um,
that's possible.
I think a lot of it is still kind of a clinical diagnosis, and then you use the ancillary studies to help support it, right?
Yeah, like injections and
Yeah,
stuff. Yeah,
exactly.
or anatomy, just plain anatomy.
Yeah, and so if they have like neuropathic or dermatomal type pain, then using the CT and potentially targeting specific nerves to try and inject make a ton of sense. But I think
Yeah.
it would start off with sort of like the clinical picture.
Here's a question directed at you. Dr. Greenberg, do your trainees get experience removing mesh for a variety of indications?
So it's very dependent on sort of, I guess, not to say luck, right? Because it's no one's lucky when we're having to take out mesh, but a lot of it is the timing of when they're on the service. Right. So we have seven or about to be eight residents a year that kind of rotate through the service. And so the mesh removal cases are certainly not daily or weekly things, right? They're a
Yeah.
little more infrequent. And so it depends on if they're on service or not. The
Yeah.
fellows who tend to stay on service, even they rotate between us as a group of attending so they can potentially see some or miss some. So it's not, everyone gets sort of variable exposure, I would say.
I think some of the goals of residency is not necessarily to make sure they're experts at being able to remove the mesh, but understand that this patient maybe needs to have the mesh removed, and then I can send them to someone to get the appropriate care. Whereas if you're not aware that that's an opportunity or like an indication, then you may say, oh, like your hernia repair looks fine,
Yeah.
right? Like this one patient that's talking about nerve pain after having Parietex and Proline mesh on top of each other. Usually mesh on mesh is not a good idea to begin with, but they may get a CAT scan and be like, you have no hernia, go home.
Right. I have
Whereas
nothing.
someone who's seen like mesh complications or a mesh removal surgery can say, okay, maybe I don't do it, but I can refer you to someone who I know at least help the patient out a little bit.
Yeah, to me, I mean, I think the goal of residency should actually be to get them to put in mesh well, really well.
Yes.
Like if
Yeah.
do that well, and then identify when it doesn't go well, what they need to do to either work it up or send them to someone else. I think that's the key, right? I think so many of our like Duke is an incredible institution, but we put a ton of residents into like transplant, CT,
Mhm.
surg onc, right? Like
Yes.
really complex
Yeah.
in different fields. And for them, they probably don't need to know how to take out mesh or even how to put it in, right? They need to know how to sew on a heart valve, much more
Yeah.
important. And so I think getting them exposure to sort of like the bread and butter aspects of general surgery and the key technical skills that translate into what they're going to do down the road is definitely the most important thing. And
Yeah.
then more nuanced stuff, I think, is what you pick up as a fellow, and then honestly, a lot in practice when you
Yeah.
become the person that these patients start to see.
Here's another question. What is your input on doctors who tell patients that a CAT scan is the only way to show a hernia? Do you think there could be updated training for even ER docs to prevent this misinformation to patients that tend to cause misdiagnosis? That's a legit question.
I think it's a great question. So one, I'm a big fan of always more education, right? Like we can all like things keep changing in our field, and it's hard to keep up.
Yeah.
So I think that figuring out ways that surgeons and physicians outside of training, where they are dedicated to education and to learning new things,
Yeah.
get exposed to new techniques, new materials, new everything like that. That's critical for our development. I think the world of imaging is going to change dramatically with AI and with everything else that's happening. Like these computer algorithms might become really, really good at figuring out like
We're hoping so.
going right, like they should, at detecting early cancers, at doing all these things that the naked eye or the human eye might miss because you're looking at it as sort of an N of one versus a computer that's looked at every CT scan that's ever been taken in every patient and like figuring out like
Yeah.
there is that things are going to change.
Yeah.
But I
I
do
got
think
approached by a company that was going to do that. They're like, you've done all this imaging research. I have all the images still, like they're stored, and I've personally review all of them and like write my evaluation. So he's like, why don't you kind of feed all that information to our system? But he wanted me to like sit down and do it all manually myself. And I was like, okay, that's a lot of
it's a lot of
work.
work.
Yeah. I
A lot
mean,
of work.
it needs to be done. I think that you're right. We need to feed that kind of good information and then have the machine learn to adapt to all that.
I still think it's going to take, in my heart of hearts, still believe it's going to take us as humans and physicians to like put it all together. But I do
Yeah,
think imaging technology and stuff is going to change a ton. And so I think that we'll have
good answer. Yeah.
help with CTs and ultrasounds that we haven't necessarily had in the past.
Yeah.
But
Um,
we can always all learn for
Here's
sure.
another question for you that was submitted before today. What are the benefits for a patient to choose a surgeon who is actively involved in teaching? That's a great question.
Uh, um, one, it's an excellent question. So
Yeah.
it's hard for me to give that answer because I've never not been involved in teaching. Like almost every case I've ever done in my entire career has been alongside a trainee. Um,
Exactly.
so
But surgeons who don't train.
I know surgeons who don't train, and I also know that they are outstanding, right? And they do so many of those cases, and they've done them all themselves for years and
Yeah.
years and
Yeah.
years. They are really good at it. So I think it's all about, to me, it's all about your comfort level.
Yeah.
Like I am very comfortable operating on patients and having trainees operate on patients under my supervision because it's just what I've done forever. And anytime that like my own internal alarm is going off that this trainee is not able to do whatever it is we need them to do, I
Yeah.
take over and do that portion. And then when it's
Yeah.
safe, I can give it back. I give it back. Um, so to me, like operating with a trainee has always been still sort of me operating, right? Because it's me talking relentlessly about like what to do and how to do it. And if they can do it, great. And we move forward. And if they can't, then it's me doing it. Surgeons who don't have trainees, they're often still operating with a partner or with a first assist or a nurse or an
Hmm.
APP or someone else. And I've had surgeons that I've coached that have done that, and I've watched their videos, and they do absolutely beautiful hernia repairs.
Yeah.
So I think it's more about your own personal comfort as a patient with your surgeon, and so to me, that's having a conversation with him or her, and figuring out like if it's a good fit. Because I think
Yeah, I think it's very humbling to teach because they always ask questions and sometimes the residents are curious or they kind of challenge you in certain things. You're like, oh, I didn't think about that. Or they bring up a different way of thinking or approaching things where you may want to be open to that. So I really like that. Plus I feel every so often I don't have a resident. It's uncommon, mostly because it's mandated by the residency that they scrub in with me. I'm not allowed not to have a resident because it's like considered to be good for their education. Um, but if I'm so used to being on the other side of the table and I'm used to like my view is different. What I do is different. So yeah, I like always having a resident trainee, and I fear that if I didn't always have a trainee, that I would fall behind. Like I wouldn't be up to date with things. I wouldn't be challenged enough. Um, but yeah, you're right. There are tons of really amazing surgeons that either operate themselves or operate with their partner, like two
Yeah.
surgeons that just do amazing things.
I remember I think I was like a senior resident. I was operating with my program director, so the person who was in charge of me as a resident. And he said something to the effect of like within 5 to 10 years you'll be bored. And I was like, that doesn't make any sense to me. Like I'm, I'm spending like my late 20s and early 30s like trying this thing. Like you're telling me
Yeah.
that in 5 years of doing it, I'm going to be bored of doing it. And what am I going to do for my life for the next 20 to 30 years?
The rest of my life. Yeah.
Yeah, like I now sort of I think I understand what he means. Like it does get less challenging, right? Like in the beginning of surgery, like everything else, like everything feels hard and new and challenging. But when you're doing your thousandth case, 1500th case, 2000th case, it does become more routine. It
Yeah.
doesn't, and it's not as important or different for every individual patient because everyone you're taking care of is an N of one and it's always important. But it does like a gallbladder, for the most part, when they're straightforward, is a gallbladder, right? And
Yeah.
then hernia is generally the same operation for a lot of things. And
Yeah.
so it's become much more automatic, and the mental energy that you spend as a surgeon kind of dealing with it becomes less and less, and it just becomes in your hands. Like you just can do it. Like a musician can play or an athlete can play. And so to me, like the challenge and the fun of it is getting someone else to do it as well as you can. And that's to me the
That's
thing that
true.
brings me a lot of joy and is in many ways, I think, sometimes more challenging than doing the operation.
So my take on that is if I had a job where I was doing, let's say, 10 to 15 hernias straight, one after another, routine, not too challenging, but good hernias, I would definitely be bored. But I've always been that kind of puzzle solver person, even as like a kid. So I don't know if I attract it or if I just enjoy it, but every patient has their own story and their own kind of like complexity that I need to try and figure out why do they have this pain? Why are they having these symptoms? And then that whole process to me is very fun. And then going to the OR and kind of proving your theory in the OR and then seeing how they do afterwards, like that to me has kept it very fun.
Yeah. Have you ever heard of the concept of flow?
Like patient flow,
No. It's a
operation flow.
psychological principle called flow.
Oh, no, tell me.
Flow is it's essentially like the psychology of optimal experience or in general like professional happiness. So you will know
Okay.
exactly what I'm talking about. So put yourself into like the first time you were maybe in an operating room or in an experience where like everything was just clicking, like the world around you is working
Hmm.
perfectly, like an hour passes in a second, like that
Yeah.
experience where everything is just like awesome, right? And like you're super happy and you're like completely focused on the thing that you're doing and time passes in like an instant,
Yeah,
right? We get that in the operating room. that's
we
that's
do.
that's this theory called flow. And
Hmm.
there's like a lot of there's a bunch of different things that have to happen for you to achieve that flow state. And part of is that if you like look at a graph, your skill and the challenge of whatever you have to do have to like line up, because if your skill is so high and the challenge is low, you're kind of just bored.
Okay.
Versus if the challenge is super high and your skill is low, you're anxious, right? You're like underperforming and you're really anxious about how you are. But as your skill increases, you have to take on increasingly challenging things, right? And so you've
Yes.
done exactly that. Like you take on the challenging things.
Interesting. I'm gonna
And
look
so
that up and read more about it tonight.
there's a book on it called Flow by a psychologist named Mihail Csikszentmihalyi. It's an impossibly spelled name. Uh,
Okay.
it's not the best. It's a little bit of a tough read, but like the it's an interesting theory and concept, and he's totally right. Like as you get better and better at whatever you're doing, you have to keep challenging yourself.
Yeah.
Otherwise, you end up just
Oh,
kind of
I'd
doing
be
the
bored.
same thing and you're bored. And
Yeah.
so for you, like taking on the puzzle people and the
Yeah.
challenging complex people
I
is what
love
keeps
it.
you
I
moving forward.
absolutely love it. Like I have friends that come and visit me in the office, because the surgery center is right next door. So it's like perfectly positioned office. So if you look at my desk, we're a paperless office, but patients come in with like, you know, several inch stack of old records and their op reports and their pictures of themselves and then their summaries and then like 10 CDs of different images and all that. And I get all excited, like, okay, here's my new puzzle, right? And my friends come in, they're like, I would run away if I saw that. Because that, like for them, that's difficult, scary, whatever.
Second nature.
And my endorphins like go up. I love that stuff. I don't know, maybe I'm weird.
No, I think it's I think you just know what drives you, right? And you know what brings
Yeah,
you satisfaction and
my
joy.
flow. I
Yeah.
love that.
And you take on the stuff that other people don't want to take on, which does a great service to patients. So I think it's
Yeah.
fantastic.
Okay, here's another question. Doctors, thank you so much for this high-level discussion. I had tissue repair over 40 years ago. Sounds like, I assume inguinal. I have developed persistent bulging of my inguinal floor, seen on exam and ultrasound, but no defect. Defect is also missing on MRI. I'll bet you wasn't read correctly. That seems to be giving me symptoms, perhaps impending hernia, Gilmore groin, I don't know. My surgeon recommends a laparoscopic mesh placement, but recommends using absorbable tacks to fixate mesh to deal with the bulging, weakness, and attenuation to tighten inguinal floor. What are your thoughts?
Um, so uh, my personal approach, for inguinals now, I tend to use no tax, and I think that's just me. I always just worry that tax can potentially hit whatever's on the other side of the muscles in the transversalis without you being able to see it. So I
I had a
personally,
patient like that yesterday. He had a dimple in the skin from a tack.
so
Yeah.
like if you're doing a TEP, you probably can, and you use either a self-fixating mesh or a non-fixating mesh. Like you can generally put it in that space as long as it's laying flat, and you watch it sort of um, as you desufflate, watch it lay flat in the right plane and space. You're probably fine. If you do taps rather than TEPs, I tend to suture close the peritoneum just to try and avoid the use of any tack fixation because
Mhm.
you can't hit a nerve if you don't fire a tack.
Yeah.
So that's my person. But again, there are a ton of surgeons who I know and who I've watched videos of who use tacks probably all the time and have really, really good outcomes. So I don't think I
What
don't
about a really wide direct defect? You don't tack those?
So for big directs, it's the one time that I usually will because I do worry
Yeah.
about stuff kind of billowing out into it, but
Yeah.
that's the only one.
You said billowing. I use billowing.
Pillows.
I know. I thought I was the only like nerd that used the word billow in her op
Oh,
reports.
good.
I love it. I knew there was something special about you, Jake. Well, I agree with you, and it's possible. So it says it was seen on exam and ultrasound, but no defect. It could just be a weakness, like a
Yeah, I mean it's
direct defect.
probably
Probably a
direct.
direct.
Yeah, it's
Yeah.
probably direct. And so for that, I think an MIS repair makes total sense.
Yeah, it totally does. And absorbable tax, if correctly placed, is within standard.
Right.
Um, oh, look at someone else wrote a nice comment. Love this discussion. Do you know, do you think you'll have time to answer the above question about occult hernia strangulation risk? Oh, sorry, there was a question that said, what are the risks of an occult inguinal hernia strangulating?
So I, I don't actually know of any data on that. So one, I think my gut instinct would be that it's probably very small, right?
Yeah,
So cult hernias being small enough that we usually can't feel them on exam. They're probably small enough that there's not going to be a loop of intestine that can get into them and strangulate and cause a
right.
problem. So my gut instinct would be it's very, very low. In fact, when you look kind of at all hernias, the best study in this was probably the watchful waiting trial that really
With
looked at
Fitzgibbons, he was on as a guest last year. Yeah.
which looked at incarceration and strangulation. So they had 700 men. Unfortunately, there were no women in the study, so it doesn't necessarily translate over to women, which is unfortunate. It's probably the same, but we don't know for sure.
You know what I say? Because I see a lot of women. I said, even if it's 10x, which it probably isn't, then 0.18% per year is 1.8% per year, which is still low.
Exactly. Right. It's still really low, right? It's like a 0.2% risk of strangulation. You're exactly
Yeah.
right. It's really small on a yearly basis. And that was for palpable hernias that were asymptomatic. And so I think for a
Yeah.
cult, it's very, very low.
Yeah. The one exception is a femoral hernia, and a truly,
Right.
like, which most femoral hernias are occult. So those are of all hernias are highest risk for strangulation. But yeah, if it's so small you can't even feel it, then definitely no bowel is going to get
Hard
stuck
for
in
stuff
it.
through.
Yeah, there's not much in there.
So I always say this to patients, and it takes the right like generation to understand the joke. When I'm
Mm,
patients about inguinal hernias, I always tell them that not only am I the president of the Hair Club for Men, I'm also a client because I've had bilateral inguinal hernias repaired myself.
that's
Uh,
generational. Yeah.
yeah, exactly. So like the other people that are younger than me, totally don't like it's just blank stares. Um, so I could have totally been a patient in that trial. Like I diagnosed myself when I was a third year resident. I clearly had a
Really?
yeah, but it wasn't bugging me, and I didn't want to like take a week off of residency to like recover from a
So
hernia.
did you have hernia repair?
Yeah, bilateral.
Laparoscopic with
My
mesh.
fellowship director fixed me as he was teaching.
Really?
Yeah, he did a really good job.
Did he use tacks?
No, he sutured close, just
Oh,
bilateral 3D Max and sutures.
yeah. And you're doing great.
Oh, totally fine. That was
No mesh implant illness.
2000, I think it was like January of 2011.
So
And
here's a follow-up question to that. Doctors, where do you place the tacks? Because I think I am the billowing patient that you described. Cooper's ligament into the transversalis fascia, conjoint tendon. Where do you place your tacks? Or fixation of any sort, I guess.
so I now use, I'm assuming we can just say like
Yeah.
product. Yeah. So
Yeah.
I use ProGrip now.
Which is a great mesh.
It's a
Yeah.
great mesh. I really, really like it. I do feel like it fixates really well. For the big directs where I do think you need additional, I'll put into Cooper's, one high up into the rectus medially, and then high lateral above the iliopubic tract. So you make sure you can feel the tacker in your hand. And those are really kind of the only places.
Yeah. So the way I teach my reds is you got to triangulate because the whole purpose of tacking, especially these large directs, is to prevent the mesh from falling into this weakened base, right? So if you triangulate it, then that should kind of reduce that risk. So yeah, I do one at Cooper's just below femoral space, one at the rectus right before inserts into the pubic tubercle, and then one just medial to the epigastrix of the rectus muscle.
Yeah.
Yeah, it's physics. It's
Yeah.
physics. Okay.
And I think
Thank-
honestly, the key to those is like like you need a big piece of mesh for those big directs too.
Yeah, you need wider.
Yeah.
Listen, I had a patient come in from a European country that should know better. The guy is German and he's like 6'4", huge guy with a good size hernia, and they put the smallest piece of mesh in him.
Yeah.
I mean, the size matters for direct, especially
Sure. For sure.
matters. Anyway, here's another question. Let's see. On the basis of your experience, do you think that there is enough evidence to support recognizing hernia surgery as a separate surgery specialty?
I think that's a great question.
Wow, I have great audience.
That's a great question.
Yeah,
I am a little conflicted about that.
tell me, because I
Because,
am too, but tell me.
well, so I mean, I think that hernia surgery is, I mean, when you look at the numbers, right, inguinal hernia repair is what it's either the most common or second most common
Most
operation.
common outpatient procedure. Yeah.
Yeah. Right. And so it's the bread and butter of most practicing surgeons. That endoscopy, cholecystectomy, appendectomy, like those are the common things. And so I don't think I don't feel like it's right for us to say like you have to be a hernia surgeon to fix inguinal hernias. Like I don't believe that to be true. I do think
Agreed.
I think people can do great hernia repairs right out of residency when they've had appropriate training. Um, I do think that for the super complex stuff, like the multiply recurrent ventrals, the EC fistulas in the setting of a complex hernia and prior mesh, like those types of things, I think
Complex stuff.
should be,
Yeah.
yeah, that should be in the hands of a few and a few sort of high volume centers that do a lot of that work because they understand what goes into it, how to take care of those patients. They have infrastructure around it. They usually have research programs around it. And to me, I think that
Yes,
that is the specialized portion of it.
for
But I
sure.
think for the bread and butter stuff, I don't think so. I think we still train people to do that. And the people that go out into practice and generally do that well, really do it well. And so I don't think that that part is necessarily its own specialty.
And what do you think the institution's appetites are? There's plenty of institutions that have dedicated hernia centers, but there are also a lot that like don't care to have one. It's not profitable to them, or they don't want to put their resources into that. What has your experience been?
My experience has been, so having gone to a couple different places where there wasn't a focus on it,
Yeah.
and making a clinical focus on it. One, like once you do, the other surgeons that have been doing a lot of it and don't necessarily love it, all of a sudden love you because like they
Uh,
focus on the things that they want to do, right? Instead of, so we had a lot of a lot of our surgeons that were fixing hernias at Duke were sort of the general surgeons. They would be partnering with plastics to do the cases. And so they'd be like an HPV specialist and they would go in and lyse adhesion so that the plastic surgeon
yes.
can fix the hernia, and patients got great care and that went really well. But also then you have like an HPV surgeon that instead of doing another HPV case to fix a cancer or something is doing.
Yes.
And so I think when you come and you sort of build those programs, the other surgeons are impacted by it in meaningful and good ways. And I think
Yes.
it just elevates the level of care that those patients get because it becomes sort of a clinical focus in a program where you try and build some infrastructure and research around it. And usually I think that's better for patients.
Yeah,
Uh,
I
so
totally
I
agree.
think it's good, but I think you have to have everyone sort of aligned and willing and interested to do it. To
And
do it,
from a business standpoint, are the institutions interested in that?
they do okay. Um, it's not it's not as good as, I mean, it's not cardiac surgery and it's not spine surgery and it's not a lot of the other stuff, but it is.
Yeah.
I think it's one. It's again, it's a high volume service, right? There's just a lot of hernias out there to fix. It means that you're giving service back to the community in which you live and work, which is good. And for the complex stuff, it's high RVU. It generally bills well. It depends a little bit on your insurance contracts with everyone in terms of how it reimburses, but in general, it does okay.
Do you get pushback from community surgeons or general surgeons in the program that like, now I'm not going to get my referrals from gynecology for the umbilical hernias or something like that?
No, because again, we one, I think we've tried to like build it as a team effort, right? Like everyone that wants to be interested and wants to be involved, like all you have to do to be involved in the hernia center is one, like submit that your cases go into a registry so that we can follow
Yes,
every.
that's very important.
And then two, come to hernia conference, like present your patients and see what other people think should be done about them. And as long as we engage in those two things and then do it, like I'm not going to tell people they shouldn't do any case or can't do any case, but if maybe we can do it robotically when they would have to do it open, they might say, oh, why don't
I
you see?
100% agree with that. Yeah. Plus the intricacies of, I'm in Beverly Hills, so there's a lot of plastic surgeons around. And, like today I had a patient with a clearly an incisional hernia, to my eyes, but, imaging said diastasis. So he's been to all these plastic surgeons that are offering a tummy tuck to a, a male that's retired. It's just like makes no sense to me. And the way that they fix it is going to be different than like a hernia surgeon would fix it. Um, but what I think is the best is getting hernia surgery specialists in every kind of institution so that when the surgical oncologist takes out a big tumor off the abdominal wall, you're available. When the transplant surgeon has a hernia, you're available. Then the spine surgeon gets a, denervation injury, you can help that. And the gynecologist doesn't know what to do with a pregnant lady with an umbilical. Like there's so many specialties that can be serviced through the hernia surgeon kind of hat that they may not even be aware that they needed your help until you're there.
No,
And he
it's
gets superior service.
and I think it's so I'm a huge believer in like everyone should do what they do best, right? So when I
Yeah.
see patients with parastomal hernias, like if their stoma can come down, I get our colorectal surgeons involved, right? Because
Mm-hmm.
to me, like, can I take down a stoma? Yeah, I probably can, but I'm not going to do it nearly as well as they do, right?
Exactly.
Can they fix the hernia? Yeah, they can, but they might not do that part as well as I can, right?
Yes.
So we
Yes.
approach it as a team. The patients then get the best of that, of both of the surgeons' experience doing the things that they do best, and they get, I think, by far better outcomes than if one of us tried to do everything all alone. Um,
100% agree.
Completely love that sort of like team aspect to
Yeah.
patient care. the bigger institutions where we have all these specialists that can do everything. It's great. It's such a privilege to practice in a place like that, I think.
I agree. I agree. And I think it makes hernia surgery even more fun because it's so cross specialty. It truly is a multi-specialty kind of application.
Totally agree.
Okay, one final question. It says, you guys are great, but I have one more question. 12 by 15 mesh question mark, and do you use absorbable tacks? So when you mentioned for these direct hernias, the large ones, do you use tacks, and what kind of tack do you use?
So if I'm going to tack, I do use absorbable.
Okay.
Again, I don't know that that makes a difference. I mean, I think to me, like most of the injuries that we see, like the problems that we see with tacks are probably if you tack a nerve, and if you tack a nerve with an absorbable or a permanent tack, you've still tacked the nerve and you've probably
Yeah.
injured. So
No.
I still like absorbable tacks just because I don't really like much permanent anything with the exception of the mesh. 12 by 15 is
And
good
the
size.
size mesh. Yeah.
Yeah, 12 by 15 is good. I mean, so most of pro grips are 15 by 10 or 16 by 12.
Yeah.
Emax is either, I think, 15 by 10 or 16. Like all of
Yeah.
them,
They're standard sizes.
like 15 by 10 is the minimum, right? It's that or bigger.
Except in my 6'4" German patient,
Yeah,
they
that
put a
guy needs
medium
bigger.
3D Max in a
Yeah,
direct hernia.
yeah. So I think
Lightweight.
large or extra large only.
Yeah,
So
I know,
bigger,
I know.
but I also think like the key is it's gotta be a well dissected space and it's gotta be nice and flat. For sure.
Yes, that's so important. It's so important. Well, my friend, that was it. Thank you so
Yes.
much for your time. Can you
Oh,
believe it?
thank
I
you for
told
the
you the hour
invitation.
goes by quickly.
It does. Thank you for the invitation. It is always great to spend time with you.
And thank you everyone for joining us on Hernia Talk Live. Don't forget, this will be up on the YouTube channel hopefully by tomorrow, or catch up with all the past episodes on our podcast. And oh, I forgot to tell you, I'm launching a hernia score, Jake. Did I tell you about a hernia score?
No.
Okay, I'll let you know the next time I see you. Um, it's a machine learning algorithm where if you're not sure if your patient has groin pain or pelvic pain due to a hernia, you go to the scoring system, put in all those numbers, and it gives you a percentage chance that an inguinal hernia will treat their groin, testicular, pelvic pain, whatever.
Oh, I love that idea.
Isn't that great?
Yeah.
Okay, it's launching soon. I have one more week to clean it up before we're ready to launch. I'll let you all know. Until then, I'll see y'all next week. We have more guests coming, and thank you again, Jake. I appreciate you. You're on the East Coast, so it's much later for you than it is for me. So have a good time with your family. Thank you very much.
Thank you.
Bye.